Hello, my name is Yasami Porkimoli, and I'm presenting our case titled Encased by Exposure, Constrictive Pericarditis Linked to Asbestos. This case highlights the diagnostic challenges of constrictive pericarditis when extensive pleural and pericardial calcification limits tissue conformation and emphasizes the importance of clinical reasoning and imaging in guiding management. Asbestos exposure is classically associated with pulmonary pathology, including pleural plaques and calcifications. Less commonly, chronic fibrotic processes may extend beyond the pleura to involve the pericardium. Pericardial calcification itself is rare and typically occurs after long-standing inflammation, infection, or malignancy such as mesothelioma. When the pericardium becomes rigid and calcified, it can impair cardiac compliance and lead to constrictive physiology. Case presentation. We present a 50-year-old man with a history of hyperlipidemia and a remote, poorly characterized open heart surgery in childhood who presented with several months of progressive dyspnea on exertion and worsening peripheral edema. He denied chest pain or infectious symptoms. His social history was notable for significant occupational exposure, including a lifelong career in farming and tile work without the use of masks or respiratory protective equipment. Given his symptoms and exposure history, further cardiopulmonary evaluation was pursued. CT imaging of the chest demonstrated extensive bilateral pleural plaques consistent with a chronic pleural process. Transthoracic echo revealed extensive pericardial calcification, including a focal calcified segment compressing the lateral wall of the left ventricle, with encroachment into the mid-left ventricular cavity. Despite these findings, left ventricular systolic function was preserved with a normal ejection fraction, and there was no evidence of intracardiac flow obstruction. However, echo features were consistent with diastolic dysfunction and constrictive physiology. These findings are illustrated in the CT and echo images shown here. Laboratory evaluation was notable for a markedly elevated IgE level of 1,183. which broadened the differential to include immune-mediated fibroinflammatory conditions. To further evaluate the pleural abnormalities, a pleural biopsy was attempted. However, tissue acquisition was severely limited due to the extremely dense fibrosis and calcification obstructing the minimally invasive window. Similarly, the pericardium was found to be markedly calcified, precluding safe biopsy and definitive histopathologic confirmation. This case highlights a key diagnostic challenge in internal medicine: how to proceed when tissue diagnosis is not feasible due to real-world constraints. Although occupational exposure and immune dysregulation broadened the differential, causality could not be established without adequate biopsy material. In this context, diagnosis relied on careful integration of clinical presentation and multimodal imaging rather than histopathology. In conclusion, constrictive pericarditis should be considered in patients with unexplained chronic dyspnea and signs of right-sided heart failure, particularly when imaging reveals significant pleural and pericardial calcification. Early recognition is critical to avoid delays in definitive management. This case underscores the importance of diagnostic reasoning and imaging-based diagnosis when biopsy is limited by extensive fibrosis. Thank you for your time.